Thank you very much for this opportunity to present to you today quite a topic that's been mentioned by most of the previous speakers, neuromuscular blockade. And I hope to bring together the points that were raised by the previous speakers and demonstrate to you the relation between AAGA and the use of neuromuscular blocking drugs, as well as how neuromuscular blocks actually affect patients' experiences of these interoperative events. As we all know, we often anaesthetists, the indication for the use of neuromuscular blockers can either be to facilitate laryngoscopy, tracheal intubation, ventilation, or at times for surgical requirements. But the administration of neuromuscular blockers actually remove the capacity of the patient to move during surgical stimulus or unpleasant stimulus during general anesthetic. But the association between neuromuscular blockers and AAGA is not a new association. It was raised previously by Gonham and Block in 1992, and they actually came up with a few methods to avoid AAGA in induction phase of anesthesia. So they said to either avoid neuromuscular blockade if it's possible, and if it were to use, to avoid complete paralysis. And other studies that actually showed that neuromuscular blocker use predisposes to the development of awareness was published by Sandon, actually showed that there's an increase in incidence from 0.1% if you had no neuromuscular blocker to 0.18% if you did. The Be Aware trial that was published in 2004 predominantly studied patients and whom neuromuscular blockers were administered. And other large trials didn't explicitly record neuromuscular block as a risk factor. So from a NAP5 results, has been pointed out a couple of times today, is that neuromuscular blockers is dramatically overrepresented in the cohort of awareness from the NAP5 reports. More than 93% of the cases in Class A and Class B actually received a neuromuscular blocking agent. And from the anaesthetic activity survey, we know that only 46% of all general anaesthetics in the UK receive a neuromuscular blocker. When we look at the groups, so different groups here, we've got our Class A and B, which we tend to just 141 cases, which most of the statistical analysis is on. But if you compare the groups now, the neuromuscular, those who received a neuromuscular block and those who didn't receive a neuromuscular block, the sparsity of the results in the no neuromuscular block made a comparison between the two groups impossible. But there's bits of information that came out. The 3 patients in the Class A and 1 drug swap patient that didn't receive a neuromuscular block, their symptomatology was fairly vague of the experience of awareness. And they modified MPSA scores varied widely from none to severe. The 7 possible cases of awareness that didn't receive a neuromuscular blocker was potentially, because of this vagueness of symptoms, is what made them being classified as possible awareness rather than certain or probable awareness. A group that we can compare is the comparison between Class A and B patients that received neuromuscular blockers and those who had unmodified awake paralysis. So if we looked at the long-term outcome from these patients, as mentioned this morning by Professor Wang, is that they actually have, whereas patients that received during syringe swaps or drug errors who have unmodified or awake paralysis has a median MPSA classification of moderate, with no long-term psychological sequelae being uncommon. But the patients who actually receive some anesthetic with a neuromuscular block and then experience awareness has a low modified MPSA long-term complications, with severe being uncommon. This highlights how the greater physiological morbidity in these unmodified awake paralysis. As mentioned and pointed out earlier today, the stress appears to be an important factor in determining the long-term adverse outcomes of patients. And more patients actually felt the stress when the experience of AAGA was associated with feeling paralysis. So neuromuscular blockers will enhance that sensation, and patients who actually had paralysis and pain, 77% of them experienced distress. this relationship between the degree of neuromuscular blocker and the likelihood of a degree of distress can be illustrated in figure 10.2. Where on the y-axis we have the degree of reversal. The black line is the degree of distress, the likely degree of distress if the patient is awake, and the blue arrow illustrating the increased motor capacity. So if you have a full motor block from neuromuscular blocker, you expect the likely degree of distress to be more than if a patient has some return or a train of 4 of more than 0.9, the distress level is expected to be less. A report of incomplete reversal at emergence actually illustrates this, where this young man underwent an ENT procedure, and then when he woke up in recovery, it appeared that he was still very weak. A further dose of reversal was given, but the patient explained that it was really horrible. He could hardly see them, he couldn't move, he heard people talking around him. He felt that his chest was too tight, he was very scared, and he thought that he would be paralyzed and unable to move, and felt it was a very bad experience, and that subsequently needed some psychological support. Incomplete reversal at emergence, as discussed by Dr. Ratcliffe earlier today, is generally caused by mistimed or mismanaged neuromuscular blocker, or the failure to monitor reversal, or the failure to actually consider idiosyncratic responses to single dose of neuromuscular blockers. There were 3 cases of mivacurium with extended blocks, and reference to genetic testing that was requested on these patients. Now, if we look at residual paralysis, it's a known occurrence. It was noted that it is an underappreciated problem in anesthesia by numerous previous authors, and that the best practice actually involves coupling inflammation from a nerve stimulator and the use of a reversal agent. And education programs previously showed how residual catheterization can be reduced from 62% to 3.5%. So this is a reasonably easy avoidable complication of neuromuscular block use. So a nerve stimulator monitors the motor capacity, but we only found that in 38% of the cases from the anesthetic activity survey that it was actually used. And this failure to use a nerve stimulator was judged as causal or contributory in half of the reports, and most of these were obviously at emergence. Because the vast majority of NAP5 reports were of unintended awareness during neuromuscular block, it actually begs the question is, what were we studying? Or we were actually studying accidental awareness during general anesthesia or accidental awareness during neuromuscular blockade. Another diagram that's in the report to illustrate the balance of the role between if you have an increased neuromuscular block, the potential of distress increases, and you need a general anesthesia to put this in a neutral position where there's no distress when you have a neuromuscular blocker on site. Now, the disruption of this balance can occur at any point in anesthesia, as illustrated. It could be during the dynamic phases, it could be during the maintenance phase. So from the recommendations, there are references to neuromuscular blockers pretty much in all the chapters. I think just a quick look, there were more than 12 recommendations relating to neuromuscular blockers, and they've been highlighted by the speakers this morning. So first of all is plan the use of a neuromuscular block. We know that 46% of patients receive neuromuscular blockers, and it'll be interesting to see if that actually changes over the next couple of years. Inform the patient about the effect of neuromuscular blockers, and the need of that has been discussed and it's still open for debate, and that there is a definite increased risk of awareness if a neuromuscular blocker is used. Patient education when we do awake extubations will also alleviate the stress that patients might experience when we plan to do awake extubation. It was touched on packaging, labeling and handling of neuromuscular block, emergency preparation of drugs, especially succinylcholine, and the need for it can be questioned. There are some recommendations that nerve stimulators should be considered as essential in monitoring guidelines. I think the current guidelines say that the nerve stimulator should be available, but I think it might be changed that it should be essential. And that the management of drug errors that lead to accidental paralysis, we had some guidance on that today, that the moment it's realized the patient is is informed, that you know that a problem has occurred, and have the appropriate management if this were to happen. Thank you very much.